Alright, as promised, we're going to do a video on setting up the vent, and hopefully you can see the screen really well. So I'm turning it on. Notice the first thing you got to do is you've got some settings here you can choose from: adult, pediatric, or we're going to do CPAP. Right now we're just going to do AC mode, and it's going to come on in volume. So I check OK for the adult, and you see my default settings. I got a volume of 450. Alright, I've got a ventilator rate at 12, my IE is 1 to 3, and my FiO2 is at 21. Obviously you can always bump that up as you feel necessary. So I've got a mannequin over here I'm going to set up. It's already intubated, so let's hook the tubing up. So as you can see right away, I can just turn it on, select what kind of patient it is, and I've got some really decent settings to get started with. Just, kind of a rough tidal volume there is 450. And what I'm going to do with that 450, that's the first setting I'm looking for to make sure my patient's lungs are not being overinflated. So I see a PIP of 29, and that looks pretty good. I'm going to look at chest rise, and I'm going to listen to lung sounds, and I'm going to listen to all the fields and make sure that I've got good lung recruitment in both sides all the way to the bases, listening down on the lateral aspects of the thorax on the patient. I've got capnography in place, and I'm going to be watching their their chest rise with this. So this is variable. My PIP could be anywhere from 15 or 20 all the way up to 30 or 35, and really that is based on how much lung volume I think I need to get recruitment. Just watch your chest rise and listen with your stethoscope. Okay. My alarm limits right here are at 35. I like that to be about 5 centimeters of water above whatever my PIP is trending at. That way I know very soon after, if something should happen, my tube gets kinked, I got a developing pneumothorax, I've got some kind of obstruction that's occurring, and that way it'll tell me a lot quicker. If my PIP is running around 20, and that seems to be pretty adequate for my patient, I will bump that alarm limit down just by hitting the button and dialing it down and hitting OK. I'll dial that down to 25. That way I know as soon as possible if something should occur. So tidal volume set. I got a PIP I'm comfortable with. Looks pretty good. My PEEP is 5. That's going to help me oxygenate the patient and just keep lung recruitment. All right. And my rate is 12. I'm going to set this. The tweak for that is, what is my end tidal CO2? Keep in mind that I want my end tidal CO2 around 40. Okay. If my end tidal is getting down between 35 and 40, this might need to be moved down to 10 and reassess. I don't want my CO2 going too low. Low CO2s will result in arterial constriction and lower cerebral perfusion, so we don't want that too low. I'd rather it be a little above 40 rather than below. So everything is set right now. I mean, based on oxygenation, if I need more oxygenation, I'm obviously going up on my FO2. If that doesn't work, I'm going to start trending my PEEP upwards. If they were still hypoxic, I would just highlight the PEEP, turn it to 7, see what happens. Give it a few minutes and see if the patient starts oxygenating. Look at them and see if they're cyanotic. If that doesn't work, we can go up a little bit more, just pushing the button to highlight. Go up to 8 or 9. Let's see what 8 does. If they're still hypoxic, I can turn it up. And much past 10 or 12, you should be oxygenating fairly well. But you got to be watching blood pressure. As PEEP goes up, blood pressure will come down. So if my patient's a bronchoconstricted patient, so if they have asthma and I've been giving them breathing treatments and intubated them, or if they've got COPD, one thing is make sure that you're still continuing to give your breathing treatment. So have your partner setting up your breathing treatment and get that breathing treatment going while you're still doing this. The important thing with them, I'm going to turn that PEEP down so the airway pressure doesn't stay too high. And I want to increase that IE ratio if they're bronchoconstrictive. So just keep pushing this button over here until it highlights it. Let's turn that to, I could go to 1 to 5. Let's see, it goes up to 1, 2. It goes all the way up to 1. Wow, it's way higher than I ever needed. So I'm going to turn back down. I'm going to go to 1 to 5 and see if I can get a little bit longer IE ratio there. So 1 to 5 for my bronchoconstricted patients. The alarm that'll set off if you don't, if you aren't getting all the air out that you put in and you're getting incomplete exhalation, the alarm will show up here. You get an incomplete exhalation alarm. couple of things you can do. You can increase the IE ratio a little bit more. I wouldn't probably go much higher than this, but I also maybe lower the tidal volume a little bit if all the air that's going in isn't coming out. Just lower that down a little bit, and then ultimately, if I've got an incomplete exhalation, just disconnect the vent tubing from the tube for just a moment and put it back on there, and watch, because you're equalizing the pressure when you do that, and then you're starting over basically. So keep that rate low on bronchoconstrictive and keep the IE ratio high. The last tweak, if there's still incomplete exhalation, is to get that tidal volume, bring it down a little bit. Just watch the pit pressure. You may have higher pit pressures with bronchoconstrictive patients, but that one right there is very good. Highest it probably goes about 35 or so, and I expect to do that at certain kinds of patients. So if you have any questions, hit me up, and that should be it. It's just basically setting up for AC patients. Not too hard.